This talk was a fairly brief one. I was really focusing on how we recognize high-risk AML, which is the important component of how it might be cured, because it's important to recognize high-risk disease as early as possible. This may be as a result of diagnostics taken up front, and obviously it's important to have this kind of information available early, including karyotype and adverse risk genomics, and also the history, whether the patient has de novo or secondary AML. But after you've chosen your induction therapy, then important information will emerge later, perhaps emerging genomic data, or the patient's, an important aspect is the patient's response to therapy, whether they've achieved a complete remission, a partial remission, or a refractory disease. And then increasingly, minimal residual disease is important in determining or recognizing high-risk AML, whether patients have high-risk MRD features, persisting MRD positivity at high levels in the blood or bone marrow, following the first or second cycles of therapy. So these kind of features need to be integrated into your assessments of assessing whether the patient has more standard risk or favorable risk disease, or whether they have high risk disease. But to get back to the point of whether high risk disease is indeed curable, I think in my talk I demonstrated that indeed it was. Long-term survival data from the MRC NCRI trials show that if you just take the patients with an obvious adverse karyotype, patients under the age of 60, the cure rate has improved over the last 20 or 30 years. Still, there is a long way to go, but the long-term cure rate is, looking at 10 years, shows that about 20% of these patients are cured. So I think the strategy that we kind of try to follow in trials in the UK is recognizing high-risk patients early enough to make a difference, which will basically to optimize transplant options for those patients, to improve the pre-transplant chemotherapy that can impact upon the likelihood of the patient relapsing post-transplant. So getting the patient into a good remission, hopefully MRD negativity, will improve outcome following transplant. And of course, better treatment, can deliver more patients to transplant than who otherwise would have not, those patients who can't, who otherwise not remit or relapse before reaching the transplant. And the final aspect of, although allotransplant is a treatment of choice for high-risk leukemia, we do need better treatment options for those patients for whom a transplant is not actually an option because of age or comorbidity. So those are my thoughts about and certainly there are data from trials that we've carried out in the UK show that we are able to deliver more patients to transplant with high-risk disease, more patients to transplant with high-risk disease who are in complete remission, and the results of those transplants have improved with different approaches of applying more intensive therapy for those patients prior to transplant.